Which of the following conditions being treated with chronic anticoagulation is most likely to lead to a thromboembolic complication when warfarin is temporarily held for a surgical procedure? A. Atrial fibrillation associated with hypertension. B. Mechanical bileaflet aortic valve replacement without other comorbidity. C. Deep vein thrombosis following femur fracture 6 months ago. And D. Rheumatic atrial fibrillation. And the answer is D. Perioperative management of chronic anticoagulation must be individualized and should take into account the patient's risk for thromboembolism while off warfarin. Atrial fibrillation with hypertension alone, CHADS 2 score of 1. Bileaflet aortic valve prosthesis without other stroke risk factors, and remote venous thromboembolism without known thrombophilia are relatively lower risk conditions. In contrast, patients with rheumatic atrial fibrillation have a very high risk of thromboembolism and are more likely to benefit from bridging anticoagulation than patients with other conditions. Perioperative hematologic issues, evaluation of bleeding risk. Procedures associated with a low bleeding risk, example dental extraction, removal of skin lesion or cataract surgery, do not require preoperative laboratory testing to evaluate for hemostasis. The assessment can be accomplished by screening for symptoms of a bleeding diathesis. For example, findings on preoperative history that suggest a bleeding disorder include large bruises in the absence of trauma, menorrhagia, especially if associated with anemia, frequent epistaxis or excessive or prolonged gingival bleeding, bleeding into joints or muscles, excessive bleeding following prior procedures, family history of bleeding disorders, medical conditions or medications associated with an elevated bleeding risk. Diseases associated with coagulopathy such as cirrhosis or renal failure are other conditions which need to be screened prior to surgery to evaluate bleeding risk. If the history suggests possible coagulopathy, laboratory tests include prothrombin time, activated partial thromboplastin time (APTT), and platelet count should be checked. These tests are often performed routinely prior to operations associated with higher bleeding risk, although the utility of this strategy is unproven. The bleeding time test is inadequately sensitive or specific for predicting which patients will have surgical hemorrhage. Management of chronic anticoagulation. Chronic anticoagulant therapy in surgical patients poses a dilemma due to competing interests of preventing thrombosis and hemorrhage. Patients with chronic anticoagulation with warfarin or other vitamin K antagonists or DOACs should discontinue the medication 5 days prior to major surgery where bleeding is a concern. The medication can usually be restarted within a day after surgery if hemostasis is adequate, although this timing of resumption must be individualized after discussion with the surgeon and the patient. Similarly, decisions about whether or not to prescribe bridging anticoagulation with unfractionated or low molecular weight heparin during the time that warfarin is withheld must be individualized. Patients at higher risk of thromboembolic complications are more likely to benefit from bridging anticoagulation, whereas the hemorrhagic risk from bridging may outweigh its benefits in lower risk patients. For atrial fibrillation, the risk is driven by the presence of other risk factors for stroke, as described by the CHADS 2 score. The location and design of a mechanical heart valve prosthesis are main factors that affect its thromboembolic risk. For patients anticoagulated for venous thromboembolic disease, the chronicity of the clot, and the presence of thrombophilic conditions are the primary determinants of risk. Risk of thromboembolism from temporary discontinuation of anticoagulation. Lower risk conditions include atrial fibrillation with a CHADS-2 score of 0 to 2, mechanical valves such as bileaflet aortic valve prosthesis without atrial fibrillation or other stroke risk factors, and thromboembolic events including venous thromboembolism greater than 12 months ago and no other risk factors. Intermediate risk conditions for thromboembolism from temporary discontinuation of anticoagulation include atrial fibrillation with a CHADS-2 score between 3 and 4, bileaflet aortic valve prosthesis with atrial fibrillation or with other stroke risk factors, thromboembolic events 3 to 12 months ago, recurrent venous thromboembolism, or non-severe thrombophilia, example heterozygous factor V Leiden. And high-risk conditions include atrial fibrillation with a CHADS-2 score of 5 to 6, embolism less than 3 months ago, or rheumatic atrial fibrillation, mitral valve prosthesis, tilting disc prosthesis, caged ball prosthesis, or recent thromboembolism are other high-risk conditions. Thromboembolic events less than 3 months ago or severe thrombophilia, example protein C or protein S deficiency, are high-risk conditions. The CHADS-2 scoring includes 1 point for each of congestive heart failure, hypertension, age greater than 75 years, diabetes, and 2 points for prior stroke or transient ischemic attack. This short case scenario is from an outstanding chapter titled Perioperative Medicine in Baliga's textbook of internal medicine, available at mastermedfacts.com. The chapter is authored by Dr. Hugo Quinny Cheng, MD, who is professor of medicine at the University of California, San Francisco, where he also completed his medical school and residency training. He works as a hospitalist with a clinical focus on perioperative medicine. He directs the medical consultation service and co-management with neurosurgery service and regularly teaches about preoperative medical evaluation, perioperative medicine to residents and practicing physicians. He also directs the internal medicine board certification and recertification review CME course for UCSF's Department of Medicine.